All right, I think we're good to get started. So my name is Sophia Poeta. I'm the program coordinator with the Pennsylvania Public Health Association. Thank you all for taking some time out of your day to join us for our October session of the Pennsylvania Public Health Lunchtime Webinar Series. Today, I'm happy to welcome Gary Klein, a Senior Data Analyst from the Public Health Management Corporation, to present on an example of the value of a local health survey in addressing the impact of socioeconomic status on health inequities. I'm going to turn it over to Gary in just a second, but we will ask for you all to hold your questions until the end. We're going to save some time to do a brief Q&A at the end of the session. But feel free to jot some questions in the chat. We'll just answer them at the end. All right, Gary, I'm going to turn it over to you.
Okay, hello everybody. For those of you who don't know me, I've been an employee at PHMC for a long time, over 30 years. And if you do know me, it's probably not from presentations like this because I haven't done that many. I'm a data analyst. However, I've always desired to do presentations. My background before coming to PHMC is dissertation in sociology. And there are things I've always, I guess, had an itch to do with the data, but never really had time. For one, I've been involved, I've worn many hats at PHMC, but more than any other, it's probably been with a household health survey and the community health database. And if you don't know, I guess you could say it's the bad news right now is that we're currently not operating. Hopefully it's a period of hibernation, but we've been for being a nonprofit and providing data to all you folks, we've been at a disadvantage in that we don't have the same government funding as entities like BRFSS does and CDC sponsored. And it's sort of awkward to ask nonprofits for money when it could go to services instead of research. So my long-term I now have some free time, but and I can do some research that I hadn't planned to before, and it's a blessing in a way to be part-time and be able to do some things I've wanted to do for quite a while. I've worked on all 13 household health surveys since we expanded into southeastern Pennsylvania in 1991, and each one had its own challenges and issues. A lot of our survey is a lot like what you'll find in BRFSS, Behavioral Risk Factor Surveillance System survey that the state is required to employ, although each state does it a little differently. We actually have used the similar vendors to do the interviews, as has BRFSS in Pennsylvania. And I want to compare, not that one is better than the other, but both are needed. And we can do things that BRFSS can't do that's of value to public health researchers and practitioners. And they can do things we can't do as well or as well as they can. But I also, other than just, supporting our survey, some research that's more sociologically oriented that I had an opportunity to do has to do with my long-term wish that there was more socioeconomic equality and less of a gap in our country and our regions. And noticing with our data just how closely our socioeconomic variables relate to health variables, and wanted to explore that. And the more they are related, the more it implies that different interventions that are socioeconomic, education, income, and so forth, should have, or one would think have good outcomes. And when I get into the implications of the research, I'll talk a little bit more about that. Uh, I just put a table up here on the screen just because I'm more comfortable with data than writing and talking. And it was very helpful to have two partners assist me to get over the hump and trying to be clear and to cover the points I wanted to more smoothly than my initial or many other drafts that I had. One of those is here today, Mary Harkins Schwartz. She was the director of the Community Health Database, and now she's a research director at the Krohn Foundation, Colitis. And getting ready for this, I discovered the virtual background, and I have a lot of pictures, but I don't know if I can handle two things at once. So I will change the background. This one looked nice, and I'm blocking Mary's face right there. I said I had many hats. One was taking pictures at parties, and this is one such holiday party where I think she's cutting cake and I'm blocking it. The other person who assisted me is also not currently at PHMC. She's a PhD candidate at University of Penn in sociology. Her name is Ellen Breyer, and she was a research assistant here and was also very, very helpful in editing drafts. Currently, the paper, it's been delayed because it's a special issue where they delayed the time frame of its submissions. It's on Health Inequalities by Public Health Journal, and hoping it gets published. But if anybody's interested in seeing our draft that's submitted, let me know and I'd be happy to share it. Most of today, my time will be covering graphs and one fancy table that has proved to be a statistic of a lot of value with public health data, and it's binary logistic regression. And my other side gig has been teaching statistic classes at Jefferson, which I no longer currently do, but I will cover that, but not enough if you're not familiar with it that you can really fully grasp it, but hopefully that's helpful. So I'm going to go to my outline. I have three parts. And first outline is talking about BRFSS versus PHMC survey a little bit. And that should come up if I click new share and this outline. And I think, is that up? Let me make sure. I can't seem to click on.
Yes,
It's up? Oh, good. Okay, I don't see my chats, but okay. One thing, I'll tell you where I first noticed this pretty blatantly was at the public at PHA meetings that were in Philly a few years ago. I went to sessions on ranking methodologies and went to the vendor sections on reports, and all the rankings were either state level, lots of measures, but state level rankings on health and socioeconomics and other factors. And there are also county ranking reports, which are well known. And I have to say, I said, well, our survey can do a little better much county data that's public health related. There certainly is census data. You have the American Community Survey and you got the 10-year census, and the billions of dollars are spent on that. So you can do that in small areas. You have vital statistics, birth and death variables, but on, risk factors, smoking, exercise, and those sorts of things, and health factors, asthma, diabetes, and just general community factors and overall health at smaller areas. What you had was BRFSS, but BRFSS is very broadly administered. In fact, in 2018, when we last did our survey, government funded BRFSS had 65, due to less funding, 6,500 interviews total, phone-based in Pennsylvania. And Pennsylvania has 67 counties, which averaged out to less than 100 per county interviews. And if you're a public health researcher and you want to know how a program's doing, or you want to implement a program in a smaller area, with BRFSS, you have 8 districts in the whole state that they do analysis for each year. Philly County's one in Allegheny County, and then you got 6 other areas. And if you want to do 3-year averages, you can go to 25 areas where some counties are alone and some areas have 6 or 7 counties. So it's broad-based. It covers the whole state. There are ways they impute county level data to get estimates for health factors within a county. And if you look at the reports, even county-based, all you see Philadelphia is always in last place or second to last place. It's sort of hard to compare Philly to rural counties like Forest, and it depends on the actual measures being used. And you see counties nearby Philly, Montgomery and Chester in first place. And just from my personal experiences, I've lived in Chester, Upland, Delaware County. I lived in Pottstown a little bit, in Montgomery County. These places are definitely pockets of need that are in the middle of relatively wealthy counties. And our household health survey does a 5-county survey where we have enough sample. We actually had more sample 2018 than BRFSS had for the whole state for the 5 counties, where we can look at neighborhoods, and we're able to, we can't look at small areas. And it is frustrating when people ask, well, what about this zip code or this town? We want to know data. And I said, well, we have census data and so forth, but survey data, we only have 50 interviews or 60 or whatever it is, but they need a case for their grants, and that we were able to be helpful. And that was a service we provided. But we're able to have enough sample and break out the 5 counties in the 31 areas, and the different terminology of what they are. They're not really neighborhoods, but they're neighborhood clusters. They're groups of neighborhoods that we form boundaries around, where the socioeconomics and health variables change a little bit. Like we have Upper North Philly, Lower North Philly, Center City, South Philly, in places like that, Southwest and Upper. We've divided suburban counties based on advice from people in those counties of where good divisions are in terms of hospital use and so forth. And I think I covered A and B. I didn't cover C yet, measures of socioeconomic status. If you're going to look at socioeconomic status, you got to measure it in a way that you can best use it. BRFSS, to their credit, finally changed their income variable this current year, 2022, but it still doesn't lead to measures that we do with the way we measure income. And there are arguments for and against, but before they were every 5,000, do you make 0 to 5, 5 to 10, 10 to 15, and so forth. Now they have breakouts and categories, but they're fairly broad. 20, and I got to look here to remember exactly what they are. 25 to 35 is one category, 35 to 50 is another. We create variables that are based on the poverty guidelines. So we can say your family's below poverty, but we also do near poverty, 150% of poverty, and 200% poverty. And in order to do that, although people don't always remember exactly their income, but we do cutoffs that are very close to those points. A family of 4 in 2022, the poverty line is 27,000. Now, if you just know they're between 25 and 35, you don't know if they're 25 and 26 and count in the poverty, or whether they're between 27, 35 and not. And that's going to be the same as you look at families of two, where it's 18,000 right between 15 and 20. You got 50-50 chance that they're below poverty. And we have cutoffs that are close to the 100%, 150 and 200. And we narrow it down questions so you're going to the right. You never have more than 5 questions to get to the right category. And doing that, we're able to, and I'll get to it when I get to the data soon, we're able to create a good socioeconomic status measure based on, on education, high school, college graduation, but also poverty level. And actually the best predictor of health status, jumping a little bit, of all the indicators is 200% poverty. Below and above is the biggest odds ratio, which I'll get to again soon. I'm not here to bash Griffiths. Maybe I'm a little jealous that they got funding, and Mary can tell you how difficult it was to get funding for a service that we provided, where before we had some big grant agencies, but after 13 renditions, we had to raise more and more, and being a nonprofit, that it wasn't fun to ask, oh, if you want this run, we got to charge you. We got to charge you for this or for that. And I'm going to add here, just because I might not fit in later, our survey, I said, is neighborhood cluster versus broadly generalizable, but random sample, both by phone, but phone interview is dying. And I know Griffiths has higher response rates than we do, but still they're less, and there are new methodologies, and we're doing one right now on a small scale, which I would call a third type of survey, hyperlocal. And that's where you pick a neighborhood that really, there's definite needs, public health needs, and the socioeconomics are low. So why compare them to the good areas when we know that good areas are much better? And we're focused in Pottstown, on the third of Pottstown, where there's a total of 3,000, a few more households, and everybody gets interviewed. We don't have to do random sample. We post cards with a QR code if they want to do it online. We can do them in person. We can do some snowball sampling of people who live in the neighborhood to get other people from each household and give them credits. And we have 1 out of every 5 households, which is sort of unheard of, interviews collected in this portion of Pottstown that's low income. And really the only way we got the funds, because it's in Montgomery County and they have funds for this type of research. And that's with Laura Sosinski, who I believe is attending today. And we'll soon report on that and hopefully do some more. So a question becomes, like, you have limited resources, what's the best way to go? And I'm leaving that question open. Do you want to do the large broad scale surveys that the government currently providing funds for state by state? Do you want to do more regional focus where you can break it down in smaller neighborhood clusters? Do you want to just focus on some specific areas? You can't do a whole country, it'll cost too much, but then you can use the data you find from places like Pottstown and apply it to other smaller areas. And that's a whole nother topic called small area analysis, where you need some real data in order to impute. If you don't have the data, you're just sort of estimating on broad, cruder estimates from larger scale surveys. But let me go to where I'm most comfortable, and that is the actual data. And I'm going to write new share here. Again, I don't present that much, so I want to make sure I do it right. I click new share. Now, I hope you see a table, and my wife's in the next room and will yell if it's not there.
Yes.
But it's there.
Yes.
Okay. I like graphics, and graphics illustrate things, but the tables have more data. And I just to give you a flavor of what I did measuring. Those are the 31 neighborhoods. And I have to admit, I stole a little bit from the county ranking playbook by instead of ranking counties, I'm ranking neighborhoods. But I use census data for socioeconomic for the region. And there's a lot of good data, and we use a special vendor that updates it for the current year called Claritas. And then I used our survey there's a lot of health measures to look at, but one that's considered to be an overall valid, reliable measure. It's the first question usually asked, health related. It is by BRFSS and by us, is just your health status. How do you rate your overall health? Excellent, very good, good, fair, or poor. And we dichotomize it like others do, because it's sort of wishy-washy, good, very good, excellent as being okay, but fair, poor, there's some issues. So we make that division, and problematic health is fair or poor. And we look at that percentage usually to predict. So that's going to be in the graph that's coming up, but this is just quickly measures of socioeconomic status, percent unemployed, college degree, and so forth. And what we did was we ranked each one of those, all 7, from high to low, and the low on each one, so they get a rank of 1, they're at the bottom, is Upper North Philly. They had the highest unemployment rate, the lowest percentage, 7% with a college degree. They had the lowest per capita income of $13,000 based on 2018 income. 2017, the year before, excuse me. Although we did have some 2019 interviews as well, which looked at 2018. And you'll see now, if all the counties were also homogeneous, you see it all Philly low, but look at the top row, Center City, their SES rank isn't near 1, it's 24 out of 31. So they're way up there, and their median household income is higher, the per capita is higher, smaller household size, so there's not as much of a gap between per capita and median. And only 5% don't have a high school degree, and only 23% don't have a college degree in Center City. So I took that data, and I'm going to show you just one more table real quick. Let me try. Here we go. This is, if you like a table, you prefer this. If you like the graph, it's the next one. There's our health rank. Center City got the highest health rank. Usually you'd say 1, but we're picking 1 the lowest and 31 the highest. And Upper North Philly got the lowest. They're both in the same county. What's the good of county analysis when you got the lowest and the highest SES within the exact same county? Our lowest and highest health rank. 7.7% of Center City residents said they were in fair poor health, adults, and an estimate of 55.2% Upper North Philly. That's the greatest variation, but each county is like that. There's usually one section that's lower SES, the lower half, and the rest are near the upper half. Delaware County's got more lower than Chester and Bucks and Montgomery. But these are the ranks. And if there was a perfect relationship between ranks, you'd expect SES to be 31 when the health is 31, the SES to be 1 and the health to be 1. You know, the numbers should match, but they're pretty close. It's one's higher, the other's higher. And here is, lo and behold, a scattergram where the initials, the M is Montgomery County, B is Bucks, and P is Philly. It's where they land on the SES and where they land on health status. And there's P6, which is Upper North Philly, at the very bottom, 1 and 1. And there's Philly, Center City, the highest on health status, 31 out of 31 areas, and 24th on SES ranking. So they're up there. And that's pretty much what was shown in that last table. in a scattergram of ranks. And the statistic that is like the correlation coefficient, where there's dots and you look at they're individuals, but these are group rankings. So it's ordinal ranking. We don't know how different one rank, 24th and 25th may be very close on one thing and not on the other. So it's just a rank correlation. And that particular statistic is called experience rank correlation, but like the regular correlation goes 0 to 1, and 0.88 is very high. It's very high. There's a few outliers, and I could see what those outliers were. It had to do with sampling. Kensington, Richmond, Bridesburg is P7, and that one had higher health than one would expect. But we know that there are a lot of people down and out in Kensington, and we didn't get to interview them. The younger were healthier than probably represent the region. So there it counts for sampling bias more than anything else, although we did try to adjust things, but we can't adjust that fully if we don't have a good range of people to begin with. I'm going to go a little quick here, 12:30. This is extracting something from the chart you just saw before, the graph you saw before, and the solid lines are SES, the dotted lines are health, and I just took the highest ranking and lowest ranking SES neighborhood cluster, I'll not say region, I'll say neighborhood cluster, from each of the 5 counties. And you'll see the dotted and the line both matching at the bottom there. That's Philly, the column of Philadelphia. And they're both at the very bottom, where you see Philadelphia at the top, Center City. The highest, 31, is the health status, and the 24 is that the point is, and I'm pointing with my finger instead of the cursor, is there. And you can see just what the gap is in each county. In Bucks County, you don't have any region that's that close to 1, but in the bottom half of the rankings. And in the bottom half of the rankings, this is the section that includes Bristol. And they're close to their health and SES. And look how different the highest is and the lowest, both on SES and on health. Chester's not as far as Park, but close. Chester County, and this section that includes Coatesville is on the lower end, and the higher one is, I forget, to be honest. Delaware, I know it's Chester City and Upland and that south portion of Delaware County, and the highest is the western portion. Upper Darby area is a little in the middle. And Montgomery is the only one where the health isn't as high for the highest SES area, which is the Lower Merion, I'd say southeastern Montgomery County, but they're still in the top half, and they're still higher than the lower SES area, but because these are the 2 dotted ones of health, but not as much. And the lower SES isn't that low, but it is lower than the higher. It's about halfway of the 31 regions. So that's just taking something from there. And I'm going to go to the next one. And this is something that I really got into. And I wanted to do this a while back, but I never really full time. Is look at not just, and there's some literature, interesting literature on it, not just where you live, but with all the, not just gentrification, but just different mixture of socioeconomics for various reasons within different regions, neighborhood clusters. How important is where you live versus your socioeconomic status? And we have 9 possibilities, because we took low, medium, high. We put most in the medium of region, of the 31 regions where they divided the best, and most are sort of clustered in the middle. And we took individual SES, which we measured with our survey, not the census. And individual, we didn't have all 7 indicators, but we had 5 of them. And we had some that weren't in the census, the 200% poverty and the 150% poverty, near poor. and they were good predictors of health status. But we had those measures. So we have an individual's respondents SES, and we have the income measure, a better way to do that. And we had enough sample that if somebody didn't answer, we didn't include it in some analyses, because we had full answers on all the SES for almost 6,000 of the 7,500 in 2018. But basically, you have 9 groups. You could be low SES and live in a low SES neighborhood cluster. That would be the darker coloring in the bottom left there. 46.5% of respondents in a lower NC, which is neighborhood cluster SES, were also lower SES. And then you have 44.1% were middle SES, which of those 5 indicators is saying yes to 3 or 4 of them. High school education, college education, 100% poverty, 200% poverty, and household income 100,000. And to get high, you had to say all 5. You had to match. And we have in the lower SES regions, and I can attest to that because I've seen it in, I know these areas, 9.4%. That's the smallest group. But even though that's the smallest group of all 9, and that's 3 there, we can do the same thing, lower 21.5% are lower SS in the middle, 53 are middle, 25 are high. And then the same with the high SES, the smallest group is the lower SES living in high. But that smallest group within our 7,500 was still 147 respondents. So we have enough sample to look at all combinations of where you live and what your SES is. And that's important because if you just go by the region, you're going to miss people that have as much need. And so sometimes certain things, and I'm not going to go into what public health issues that could affect and not affect, but the individual, may be more important than where they live, or maybe if they live in a better area, their health is better. That's what I want to find out here. And again, we're just using health status, but it's a good general overall measure of other health factors that could proxy. Okay. So that's just showing you where they live. And then down a little below is what their health status is, the 9 groups. And there you see, right, 9.3%. That's higher SES, living in a higher SES area, 9.3% reported fair or poor health. It's almost the same for middle SES, living in high, 11.7. It jumps the 11.9% who live there. Of that 11.9% live there, 23.2% of them are in fair or poor health. So it's much higher. They're not equal to the higher SES in their health status. They're living in those general areas. There are pockets that are more than others. I just heard a big crash, but in my ear. Okay, and now if you look at middle, there's quite a variation. The upper doing the higher SES are doing much better. They're doing as well as even a little better than if they live in a high SES neighborhood, but that's infinitesimal to worry about. And if you're poor, you're doing pretty bad. And if you're on the lower SES or live in lower SS, you're more likely to say fair or poor health. But if you're high SES, living in a lower SES area, you're still rating your health very good, very good, excellent. Only 6% say fair or poor. It could be relative deprivation issue. I don't know why it got even better, but there could be some data issues as well. So there is something called, that looks like an interaction effect, where the combination of being low SES and living in high SES improves your health status, is better, but it's still not closing the gap very much. To me, that was enough to work on. But when I submitted our article to, I won't name the journal, they said, where is the statistics? And I said, oh, that's enough. Okay, I'll do the statistics. That's what I'm known to do. And I've found a lot of value in what's called binary logistic regression. And I can't do justice to this table in 5 minutes or 3 minutes, but I'll just motor mouth a few minutes and try not to get off track. There are, if you know multi-regression, binary logistic regressions, it's an attempt to mimic it with something called odds ratios that have certain statistical properties when you take a logarithm of odds ratios. If you couldn't do that, there was really no need to report odds ratios when you look at crosstabs and percentages, because you have something called a relative risk ratio, which is far more intuitive. But odds ratio has these statistical properties that allow you to do multivariate analysis and adjust the odds ratio like you would a standardized beta coefficient. But without going to all that, they tend to be close to relative risk ratios. They can vary at times more extreme. But the p-value tells you whether the significance, and the further the odds ratios from one, the more likely it is to be significant, and the stronger the odds of one group doing better than another. Now, I want to compare the suburbs to Philadelphia, so I'm reversing the odds ratio to make it over one, because under one, it can only go to 0 and it's hard to interpret. So you're seeing a reverse odds ratio where it's really good health compared to Philly, because I want to compare the suburbs to Philly. And you'll see Montgomery County, if you go to block 1 county, that's where just putting county into the equation, the odds are 2 times greater that they're going to be in better health than Philadelphia. And Bucks and Chester are close. Delaware County's not that far, and you see only 1 asterisk, 0.05 instead of 0.01 next to that. Blocks, I'm adding a block the next time, block 2. I'm adding neighborhood cluster. Now, if these county reports were great, we could stop at county and say, okay, that's all we need to know. Philly, bad, needs a lot of health implementation of programs throughout the county, so forth. We don't have to worry about the others, Montgomery and Chester High. That's not true. When we look at the neighborhood cluster SES, what happens is we're controlling for county. Does knowing county tell us anything more than the cluster? And you'll see all those 3 asterisks now become NS, not significant, except for Montgomery County still a little bit. And I'm going to admit Lisa here. Hello, Lisa. And you'll see that once we add these neighborhoods, let me maximize it again and scroll down a little bit. You'll see the 3 asterisks back again, because if you're low SES compared to high, regardless of what county you live in, and we showed that each of the counties have a low SES segment, the odds are 2 times greater you're in fair or poor health. Now reverting back to fair or poor health, because we're comparing the high SES with 2 dashes are. And if you're middle SES, you're almost likely, odds are 1.5, 446, 0.001, highly significant in predicting fair or poor health. So once we know these neighborhood clusters, which we do with our household survey, but we don't know from county reports or PRFSS, you're finding a lot of predictive value of that. And the third block is going to go one step further with our household health survey. We have individual data. We're not doing these reports, we're aggregating all these different numbers and ranking, but we know each individual, what their health status was, what their socioeconomics were. Census doesn't tell you individual data, so you can't do things like that with census data, even if they ask health questions. But look at that 6.09. That's a big number. Nothing else is like that. Even 1.91 has 3 asterisks. The 6.09 would have many more asterisks, 0.0001. It's not by chance, by a long shot. And the odds are, if we know the county they live in, and we know the neighborhood cluster they're in, we saw that low SES live in there are pockets in high SES neighborhoods and middle. They are still, the odds are 6.09 greater of being in fair or poor health than if they were high SES. So that when you see something that strong, you gotta really focus on socioeconomics and figure that we all know socioeconomics have an effect, but I would never expect that high of an effect, and that just means that they really are going hand in hand. But whether it's more income related, education, you have to look at the different indicators, whether it's more certain types of health, mental health, physical health, based on the neighborhood. You have to look at that. Maybe some neighborhoods are better because they have more parks and more community efforts, even though they're poor. Whatever the case is, the SES of the individual has a lot to do with how their health status is. And you can also argue it costs more the poorer you are, and maybe we'll save money by implementing things like stimulus payments and things like that may prove beneficial. And we could do studies if we have hyperlocal surveys like Pottstown, where before and after, we really have smaller neighborhoods that we have enough data on, and we can do before and after studies. And I just think, and I'm jumping to the conclusion that it's getting a little passe to keep doing phone interviews with all the difficulties. We're trying new methods that are more state of the art, that involve different ways of collecting data in more local areas to see what's really going on in terms of poverty level and education, which still varies in those neighborhoods. And what public health trusts will need, they need local area data. And even with our wonderful household health survey, people would say, I want to know this zip code or these census tracts. And we're not hyper local, but we can do best with a region. And that was often enough for a proposal, but not for the actual evaluation. I wish I was younger and did this earlier, but I was doing too many other things, and I just sort of germinated in me. And now that I have time, I feel I got this out of my system. It wouldn't have been possible without Mary and Ellen pushing me on. It's hard to work on your own when there's no funding and you just want to do something. And I went through the outline of part 3, but I'm just going to push it there. And I think I did enough to share it. And methodological importance, people who want to do small area analysis, we need data on small areas to do that in low income areas. Practical, theoretical. We can talk about SES versus just cultural factors, essentially good health. And there I talk about local survey analysis, quasi-experimental research. And it's 12:47. I'm sure I forgot things. I have my note cards I'm scared to look at because I didn't cover things. But I do want to applaud the state for the EDI system and generating quick data. It's wonderful. And there's a lot of good BRFSS data to know what good baselines there are. And I didn't mean to sound like PHMC data versus BRFSS. I just wish maybe every other year they did BRFSS and then they did a small area in between different demographic characteristics and incorporated other things besides telephone. The big change was incorporating cell phone. BRFSS gets a high response rate, but still it's going down, and there are issues with that. And I think I'm just going to stop here. And I have my, now that I need the headphones, and anybody can ask me anything they want, and I'll do my best to be quiet till I hear a question. And I'm not sure if chat mode, I'm going to click on chat and see if anything's there. No, or I don't see anything, but any questions? And I hope I didn't lose everybody here. Okay. Let me check the participants, 22 of you. Okay. Okay, well, more, I don't see anything or hear anything.
I think there's a couple questions in the chat now, Gary.
Gary, I can read them out to you if that helps.
I'm sorry, my hearing, I'm
There are
hearing aid wear.
3 questions in chat. 3 questions in chat.
Oh, good,
Yeah,
okay,
check your chat.
okay. This chat, I clicked chat and I don't see anything.
One question, Gary, if you can hear me, is asking about if you can comment on face-to-face versus phone surveys.
Okay, yes. Why I like the Pottstown study so much, it's not a random survey. So you don't have to say, oh, we want to go to this house or that house, or everybody in the neighborhood has a code and they have to give that code, and a person from the household will do the survey. Online is the easiest way with postcard, but then you know who did it and did not. We have their address. We can go to their homes. It's awkward to just knock on doors. Drexel students have done that with mixed success. You have to have the right people to do it. We felt that even though it's not totally random, that snowball sampling has a place, because you're never going to get the hardest to reach groups by whether it's phone or just going to doors. And that is younger minority males in particular. And we were not getting enough, especially in the poor realm, and interviews are the best way. We had libraries set up in Pottstown to do interviews. We had people come to events. I wish there was more. If we had more resources, we're still a little short. I'm supposed to be the waiting guru to even all that out, but I hate counting someone who's poor and minority 5 or 10 times more people, counting as 10 people. That's what waiting does compared to a female who's older, who's much more likely to have participated even with those efforts. So face to face, but you can't just do churches or just do events. You want to get different places to get people. And a thing I really wanted was to give incentives out to people who participate in the survey who are lower SES, and give them rewards for recruiting more people. I don't know how well that's working, but we try to have ambassadors, people volunteer to capture interviews. So I'm saying things are still a struggle, but we still, regardless, have 1 out of every 5 households participating within a section that's about a third of Pottstown Township. Okay, I'm gonna show conversation. I just see the beginning. I probably have people blocking it. Let's see. Chat.
No other questions have come in at this time.
Yeah. Okay. Is there another question in the chat? I don't see him.
Not at this moment, no. If anyone
Okay.
has any other questions, feel free to put them in the chat. If not, we can give everyone 5 minutes back to their day. Unless Gary, you have some other things you want to wrap up with.
Okay, you know what I want
No other questions.
to, okay.
You can wrap up if you want.
Okay, I'm gonna wrap up. If I can do this quickly, just to be a little lighter. I'm gonna change my backgrounds. Share. I was in Cuba 2 years ago, or right before COVID, 2020, in February. And this is a painting at a restaurant on a wall. And I really found how even though there's poverty, with a lack of a socioeconomic gap